Lynn is largely responsible for the big improvements we have made in treatment. She's the one that runs our clinics, and she's the one that finds the new protocols. So, for example, she took us from 5% success with terminal stage 4 cancer to 77%. And she was in the NHS for 30 years, and now she's spent 6 years with us.
I'd like to introduce you to my friend Lynn Tyre. Lynn is a UK state-registered biomedical scientist, and she worked in the UK National Health Service for 35 years. Thank you, Lynn.
Okay, thank you very much, ladies and gentlemen. Right, we're going to discuss terminal pancreatic cancer. It's something that nobody likes to treat. The prognosis is usually bad. This is actually the basic anatomy of the pancreas, and it's kind of hidden behind other organs. It's not easy to find, and when anything goes wrong, it's very difficult to do anything with it. As you can see, pancreatic cancer is very difficult to diagnose. The symptoms are very non-specific, and while other deaths from cancer are actually improving, the deaths from pancreatic cancer have not improved. Their survival rate is only about 4.8%, 5%. I mean, the symptoms are basically, it's a silent killer, and they're vague symptoms. So you get you'll get stomach pain, you'll get vomiting, weight loss, and malabsorption, and you'll get some epigastric pain as well. So early diagnosis doesn't improve the prognosis. Pancreatic cancer is very, very aggressive, and it grows quickly, even if it's stage 1 or 2. The majority of the pancreatic cancers are to do with the exocrine cells, and they're pancreatic ductal adenocarcinomas. There are other types of pancreatic cancers, but that is the main one. The treatment of the cancer depends on the staging. When it's stage 1 and 2, they will use chemotherapy. By stage 2 and 3, it's started to break out, and stage 4, it's metastasized. If it's found on the body of the pancreas, they can actually do a surgical resection technique called the Whipple procedure, and that's basically, they take out the cancer and they sew everything back. Okay. If it's on the head of the pancreas, it will actually block the common bile duct, and that way all of the bile salts and that will be backed up into the system, causing jaundice. If that happens, the doctors will put in a stent to try to get rid of the bilirubin. Oncologists use chemotherapy and radiotherapy for pancreatic cancer. The goal of that is to stop the metastatic process. They hope that chemotherapy will shrink or stabilize the disease, but it's not a good candidate for chemotherapy. Well, that's a lot of bad news about it. The good news is pancreatic cancer can be stopped in its tracks if the patient follows the protocol. They can be symptom-free in a very short time, and even completely free of symptoms, and the cancer will be reversing in a very short time. So how do we do this? It's an aggressive silent killer, so we need to do something really serious with it. Firstly, the doctor will look at any lab work, the CT scans, PET scans, and to see what stage of disease is and progression. In our clinics, before any treatment at all, we actually look at the pancreas and to see what baseline values we've got. We try to find the tumour, identify it, and measure it. That little tiny mouse was helping us out. No, he wasn't. He was in the other lab. Okay, so this is Paul. He had a carcinoma of the pancreatic body. On Monday, we took the measurement, and then again on Friday. There was a 26% reduction in the tumour mass in a week. And within the first week of treating him with the Swiss protocol, he was able to produce insulin, and he had to then monitor his blood sugar levels because they were returning to normal. So he had to carefully work out how much insulin he needed to take because he was going into hypoglycemic coma or events because it was just getting too low. Okay. When it metastasizes, like with other diseases, like the breast cancer will go to the lungs and then to the brain, pancreatic cancer, when it decides to metastasize, it usually goes to the liver, lungs, abdominal cavity. So what we do in the clinics is we want to target the lymph nodes which surround the pancreas. We want to try to get the GoLake to go to the pancreas by using the inguinal lymph nodes, which are the ones in your groin. The patient is then nebulized because the lung is a big immunological organ. It's got its own macrophages there. They can actually then stimulate the immune system. And the patient is given a suppository containing GoLake. So if the cancer has metastasized to the liver, it may only be a few cells, but it could happen, we actually give them suppositories to target the hepatoportal route. And because it can go into the abdominal cavity, the patient is given a probiotic yogurt which contains GcMAF. Because the pancreas in normal carcinomas is functioning, we kind of don't do very much. But because the pancreatic cancer, they are not able to always secrete pancreatic enzymes, so we supplement with that. And we also, there's a compound in nigella seeds which has been documented to help with pancreatic cancer. Okay, so the patients are obviously quite scared. The pancreatic cancer have been given 2 weeks to live or something like that. So we try to give them something that will help them, visualization. So we take them, we use ultrasonography and we show them their spleen before we do any treatments. And this is the spleen on the screen, and you can see there's not a lot of coloration there. We use the Doppler effect to show activation. Then after 1 hour of GoLake treatment, which is at the end of their treatment thing, the splenic blood flow was observed, and we can see an increase in the actual blood flow. Macrophage activation can also be assessed by monitoring the blood pressure. Once the macrophages become activated, they actually secrete nitrous oxide, which causes vasodilation. So this then causes the blood pressure to drop. So before treatment, you can see we measure the blood pressure, and then after, they always consistently see a decrease in it. Right, I've discussed Paul, whose carcinoma was in the body of the pancreas, and he didn't have any known metastases, but we still gave him the treatment to target the liver and the abdominal one. Frida was a different lady. She was one of our first attendants in the clinic. She had pancreatic cancer, which had spread to her stomach, and she actually had so much acidic fluid, she looked like she was pregnant, and she was in her 70s. Okay, this is an ultrasound of her. In the first week, the top left, you can see hypoechoic presentation, which means there's a lot of water there. But as the treatment was going, the water was slowly diffusing and being eliminated. The dark colouring has gone from the next 3 slides. And she was a bit difficult to do. We couldn't actually get to her pancreas to start off with because of the fluid. And the last one I'm going to talk about was Virginia. Her son came to my house. He was really upset. He was crying. His mum had been given 2 weeks to live. I thought, well, you've got to give them a chance to see what we can do. She was well enough to travel to us, and the next day, a heavily jaundiced lady arrived. She was so jaundiced, her eyes were yellow, her teeth, her nails, and she was also very underweight. We gave her an ultrasound on admission, and it showed the carcinoma in the head of the pancreas. So this was pressing against the liver, causing obstruction and everything. The local hospital put a stent in to try and resolve the obstruction and to get rid of the bile to drain into the gut. But the stent didn't work. The cancer was too aggressive and it was growing and it blocked the stent. So she was in quite a bad way. Because she'd lost a lot of weight, I looked at some of her blood test results. The CRP, which is a non-specific measure of infection, was 259, and it should be up to 3. She had an albumin which was low because of the poor nutrition, and her bilirubin, which showed the liver involvement, was 323. So there is a blockage. The stent isn't working. There is a calculation that you can do, and it's called the Pinney score. It's a measure of nutritional index. And I looked at her and did the calculation, and we arrived at a value of 86. I was told by my professor not to treat anybody with a Pinney score over 20. They're not going to make it. Hers was 86. She was in my clinic, I had to do something. I couldn't say no, so we started her straight away. She was nebulized and shown where the inguinal lymph nodes were located so that she could do injections if she wanted. She was offered suppositories to target the hepatoportal route, and she was also, we made and gave her the yogurt containing GcMAF. We talked about supporting the liver and kidneys during the treatments, and we said she needed to have structured water to sort out the subclinical dehydration, and she needed to do juicing to remove any heavy metals and toxins from the procedure. Many of the population are magnesium D deficient, so she was advised to have blood tests to see if she was deficient in any of those, and other supplements were discussed. She understood that the lifestyle changes were for life. You know, she couldn't just suddenly go back to her old ways of eating or living. And after 2 weeks, the bilirubin was, it's 125, and her Penny score was reduced to 25. It's still in the high risk category, but she was surviving quite well. She was putting on weight. Yeah, so basically all of her levels were resolving. Her teeth and nails were losing their yellow coloration, and her consultant oncologist didn't know what was happening. She hadn't told him that she was seeking integrative treatments, and she was feeling so well after a month that they took a 3-week holiday to see her family. The treatment plan worked. And it's not the first time. Pancreatic cancer, if you use that protocol, is quite easy to resolve.